Hello, everyone, and welcome to the TMA Ask the Expert podcast series. Today's podcast is entitled Nerve Transfers and AFM Part 1. My name is Chrissy Dilger, and I will be moderating this podcast along with Rachel Scott.
My name is Rachel Scott. I'm a parent of a child with acute flaccid myelitis and also a founding member of the Acute Flaccid Myelitis Association.
This podcast is being recorded and will be made available on the TMA website for download via iTunes. During the call, if you have any additional questions, you can send a message through the chat option available with GoToWebinar. For today's podcast, we are pleased to be joined by Dr. Amy Moore and Dr. Dan Zlotolow. Amy M. Moore, MD, is an associate professor of surgery at Washington University School of Medicine in St. Louis, Missouri. She is the chief of section of hand surgery and serves as the program director for the Hand and Nerve Fellowship in the Division of Plastic and Reconstructive Surgery. Dr. Moore is a surgeon scientist who specializes in complex nerve reconstruction of the arms and legs. She currently runs 2 clinical trials involved in nerve regeneration and also performs translational basic science nerve research that is funded by Department of Defense. Dr. Moore began treating patients with acute flaccid myelitis in 2017. Her contributions include developing novel nerve transfers to restore hip and knee movement. She is committed to providing excellent clinical care to both children and adults affected with acute flaccid myelitis. She is also studying the nerves of her patients in her laboratory in hopes of better understanding this rare disease process. Dr. Moore is confident that with increased awareness and research, we will be able to improve outcomes in patients affected with AFM.
Dr. Zlotolow is a pediatric upper limb and peripheral nerve surgeon at the Shriners Hospital for Children Philadelphia and Greenville, the Philadelphia Hand to Shoulder Center, and the Hospital for Special Surgery in New York. He specializes in the care of arthrogryposis, brachial plexus and peripheral nerve injuries, spinal cord injuries, complex post-traumatic deformities, congenital differences, and limb deficiencies. His interest in acute flaccid myelitis began with 2 children in need of nerve transfers and has expanded to caring for over 60 patients thus far. He leads medical outreach missions to Havana, Cuba, and Kigali, Rwanda, and has founded 3 professional societies, including Plexus Nexus and the Pediatric Hand International Society of Surgeons. He travels nationally and internationally as a visiting professor and lecturer. As the fellowship director for the Shriners Hospital Pediatric Hand Fellowship, he oversees the training of 16 fellows each year. He was a team leader for Zion, the first pediatric hand transplant.
Welcome, and thank you both for joining us today. So to start us off, for those with acute flaccid myelitis, nerve transfers have become a possible solution for areas that don't seem to be gaining function with traditional therapy. Dr. Z, can you explain the basics of nerve transfers and how it specifically benefits kids or adults with AFM?
So the basic concept of a nerve transfer is that if you have a nerve that isn't working, but is a critical nerve, and then you have a nerve that is working, but is something that is expendable or redundant, meaning that there's more nerve going to a muscle than you need, or there are 2 nerves going to any specific function, you can borrow one of those nerves that you don't really need and move it into a nerve that is not working. So the basic idea is you're trying to get electricity from one place where you have more than you need to a place where you don't have any.
Great, thank you. And Dr. Moore, do you have anything to add?
No, I love that. I mean, I think the concept of the body has a lot of extra electrical signal that we can maintain, function, but also steal a little bit from it to give us new motion in other muscles. So nerve transfers are, they've been around since, the early 1990s, but applying it to patients with AFM is just so novel, but very exciting.
Yeah, one other way to think about it is that you have every nerve has a built-in about 2/3 to 75% redundancy. So there's a lot of redundancy built into each and every nerve, and that allows us to borrow without really causing any deficits in the nerves that we're borrowing from.
Okay, great.
We have a lot of parents, mostly in 2016, who have started taking advantage of these surgeries, and it's become a very hot topic in our community of families. So we want to go through some questions that families typically are asking to determine whether or not their child or their loved one is a candidate for nerve transfer. So what diagnostic tests can be done to determine if someone is a candidate? And we'll ask Dr. Moore, sorry.
Yeah, sure. It's hard. It's a hard answer, and it should be so clear. But really, in my practice, I have determined whether a patient is a candidate by their physical exam. And I do use adjunctive measures such as EMG and nerve conduction studies. But with children, these have been less reliable for me. And so when I have my hands on the patient and I can figure out what are they missing and what do they have, then that is what I'm using to create my plan for the operating room. There's no very concrete, this is yes or no. I talk to a lot of families over the phone, and what I found is that I understand it's difficult to travel to St. Louis, but I really can't distinguish whether your child would be a candidate without really putting my hands and examining them.
So do you generally do an EMG or any nerve conduction tests?
I try. I know we want to, through the CDC work group, we really are trying to standardize what we need. Thankfully, I have Dr. Z and in the Shriners, Dr. Beth Lipa, who provide really great studies for me. My electrodiagnosticians here in St. Louis are a bit less comfortable. So although we get it, and it's been very helpful of saying, oh, it's working or it's not, it's not a make or break whether I'm going to do a surgery.
Yeah, can I add to that?
Yeah.
Yeah, so I would completely agree. I think that very often patients come with an EMG examination or nerve conduction studies, which can be very painful for the child. And I would tell you that 90+% of the time they're not relevant. We don't use them to make any decisions. It's really for us, and I'll explain to you why I think in as much detail as you wish or we have time for. But basically, the way it works is if a muscle isn't working, then you know it's not working. There's no reason to test that muscle with an EMG or nerve conduction. We know the nerve is not working. We know the basic pathophysiology of what's happening, meaning that the anterior horn cell has been injured, right? And so we know that. We know that if it's not working, the EMG is going to look bad. So I'm not sure what the point is of an EMG. The few times where we do use an EMG is to determine if the donor, meaning the nerve we're going to use that we think is normal, is in fact normal. So that's the only way in which we use EMG. We don't use it to diagnose the deficiency, meaning the need for a nerve transfer. We use it to diagnose the ability of us to use a donor to transfer into the defective nerve or the injured nerve. And we don't do that all that often.
And the only thing to piggyback that on is that we're getting these studies and retrospectively, we may be able to pick it out when we study the outcomes and we have longer term follow-up. We may be able to go back to the electrodiagnostic studies and say, oh, wow, look that we found. But I completely agree with Dr. Z that I'm not using it to determine my course in the operating room, although it's adding to my understanding of the severity of the child's disease process.
Well,
I would say the same thing for imaging tests.
Well, that was my next question, because a lot of parents, some neurologists recommend follow-up MRIs, and there's been discussion that may show indicators of what areas will not regain function and may benefit from a nerve transfer. So do you have an opinion on whether or not a follow-up MRI is helpful?
Can I say first?
Yeah, sure. I was gonna let you.
Yeah. So the answer is no. I think the benefit, the only role of an MRI, I think, is to establish the diagnosis. In my mind, the MRI has no, the MRI of the cervical spine or MRI of anything has no bearing on prognosis or on course of the disease or on what you're going to do surgically. It really doesn't have any bearing, because the only thing that matters is what can the child do and what can the child not do. And that's what you base your treatment decisions on. I've never made a decision based on an MRI. I don't know about you, Amy.
No, I haven't. And again, it comes down to trying to understand the disease process and trying to fix the disease process. And as surgeons, we don't, I mean, I really care and I really want to know, and I love studying the nerve, so I don't want to diminish this, but it's not going to impact what I physically do as a surgeon. It doesn't take away the amount of information we may get about the disease process. So when I get asked this question from parents, and I really do, I also say you have to just weigh the risks of the anesthesia for your child to undergo. What does that mean for your family? What's the cost? What's the impact? Because it's not going to change what I do as the surgeon. I feel like if I frame it that way, I'm sure we're going to get information that will be helpful. So I don't want people to feel like it's not helpful information. It's just not for the surgeon.
Yeah, I would say to echo what you're saying, Amy, and to distill it into a phrase, I think the MRI, the EMG is not really for the patient. It's for us to learn more about the disease. I think there's limited role in how those will benefit the child per se, but they may help us help other children if we can correlate some of that with what's going on with the child. But it's not a, yeah. So it's one's for us, one's for them. Is that fair?
Yeah, thank you both so much. And so as a follow-up to that, I guess, if you could tell us what indicators you do look for in a patient, and if there's any kind of exclusion criteria that would disqualify a patient for consideration. Dr. Moore, do you want to start us off?
Yeah, sure. It's great. I love doing anything with Dan, and because it's like I feel like we're so on the same page and we sort of have the same go at it, which has been why it's been so great to treat these patients. But when I think about the exam, I care about what is working and the strength of that muscle, and that determines what I can do. I think it's that simple. Is that sort of the question you're having? Like, what is it going to be? Well, it means that there's a strong enough function that I can take that's redundant that I can transfer.
Great.
Yeah, exactly.
Anything to add? Okay, great.
No, I think the one thing I would add is this. When we, there's sort of an old-fashioned way to go about this and we're kind of old-fashioned people. Amy and I. So
speak for yourself, Dan. Speak for yourself.
Yeah, right. So the way that has been done traditionally is you make kind of a list of the muscles that are not working, and then you make a list of the muscles or the nerves that you have that are working, and you look to see which nerves are redundant, which nerves do you have more of than you need, and then which nerves are not working, and you basically connect from column A to column B, and you say, for example, I don't have any nerves that go to the rotator cuff, but I do have a spinal accessory nerve, and the spinal accessory nerve is expendable, meaning you can lose it and not lose any noticeable function. So therefore, I'm going to draw a line from spinal accessory nerve to suprascapular nerve, and that's going to be one of my transfers. And so the way that we make decisions, and I think Amy and I do the same thing, is we make decisions by what's available to transfer and what do we need. And we try to match those. Obviously, you can't, if you have an extra nerve in your hand, but you need a nerve in your neck, you're probably not going to use that nerve, right? So that's all it has to be local. it has to be expendable, and it also has to have enough juice in it to be able to power the nerve or the muscle that you're hoping to power. And I think that there's I don't think we have a hard and fast rule as to who is a good candidate or a bad candidate. I can tell you the person who has no function at all, I think, is not a person that we can really help, because there's nothing to borrow from. Does that make sense?
That's exactly right. I have the same problem. Like, that's the most heartbreaking conversations that I have with parents, is seeing no motion of the entire extremity. Because those are where I don't have anything that I can steal from. And that's a really, that is an exclusion. I cannot help you.
Is the age of a patient a consideration in deciding if they are a good candidate?
Age meaning from age of, like,
well, that's two
chronological age, or
different
age
questions,
for
I guess.
diagnosis?
Yeah, both of those actually.
Well, I think from the first cohort, and so when I started thinking about these patients with AFM, I think of the 2016 diagnosis as a cohort, and then the 2018 patients as a cohort, because we really learned from 2016 to what we treat and do in 2018. And so with that cohort in 2016, we didn't really get these patients in a timely fashion. And my average operations for the 10 to 12 cases that I did for that cohort was over 13 months from their diagnosis. And I think ideally we now know that 3 months is too early, 6 months is probably too early, and we want to be before a year. But of patients that I did at 17, 18 months, I am seeing recovery. So it's not an absolute. I think we have a longer window than we were otherwise thinking, but we don't know for sure.
Yeah, our experience has been fairly similar, actually. And talking to Mitch Saruya, who also does a fair amount of AFM work, we've all had, I think, the same experience. The traditional teaching in terms of nerve transfers is you want to get to it. And some of that's from our data as well. I mean, Amy and I have looked at this in terms of nerve transfers, and really the sweet spot is before a year for the general nerve transfer patient, but not the AFM patient. So we kind of are extrapolating from that data into the AFM population, but it doesn't necessarily correlate, because there may be some special things that are happening in AFM patients that are not the case in other nerve injuries. And that is that the muscle may be maintained in a better condition in patients with AFM than in the average nerve injury patient. And we think that has to do with the fact that because only the anterior horn cells are injured, some of the other support cells that keep that muscle alive with some sort of nerve, the nerve kind of produces basically molecules that keep the muscle in better shape. And those other support nerves that are still functioning in AFM may be keeping that muscle alive longer. We don't know for how much longer. We can't say that, this is, will extend the life of the muscle by a year or 2 years or 20 years or indefinitely, because we just don't have that data. But we do know that muscles are preserved for a longer time, because these nerve transfers that we're doing late tend to be working better than for other nerve injuries. Amy, do you agree with that? I don't know if
No, I completely agree. I mean, and I've tried from a scientific standpoint, like thinking about any literature we know about muscle cells, and the afferents, which is a type of nerve fiber which is present in sensory and in motors, are coming from the part of the nerve in the spinal cord that's not injured. And so I totally agree. I think that this helps. I really do. I also think that for the majority, these children are young, and our capacity as children for regeneration, for keeping muscles alive, is high. And so I don't know, I was talking to a family yesterday that if you're under a year from your diagnosis, there's no way that muscle's dead yet. It wouldn't be dead in an adult. It's certainly not going to be dead in a child. But again, we don't know enough about this disease process to really, say much more than that.
Okay, great.
Yeah,
Thank you.
No, I was just going to say, so I think the short answer is that until we have better data, we will try to do the transfers at the time, sort of that sweet spot between 6 and 12 months. But that doesn't mean that if you're 2 years out, you're too late. Because what's your other option, right? So if there are no other options, and this has maybe a chance of improving your function, I think it's still worth doing as long as the risks are low.
Actually, that was going to be my next question about 2 years out, because I think that a lot of parents, we did get a lot of questions about timeline and parents being worried because their child is more than 2 years out. So I think that would be reassuring for them to hear that maybe that it's not too late.
Well, I mean, and take that into account of what we're asking and what's available to get back, and coming to the priorities. I feel that we're hitting 2 years, and I want to say I operated on a 2014 cohort patient, and it wasn't that we got great return of function. It was just that maybe we, sparked whatever was present there. I'm not sure, but at 2 years, I would start having the expectations set differently, but not that I wouldn't do it.
Yeah, I think you're looking at, we don't know what the percentages are, but clearly the sooner you get to it for any nerve transfer in general, after you establish that the nerve transfer is necessary. So this is what we're talking about, the sweet spot, right? Children are still improving past 6 months. So 6 months may be too early, right? By about 9 months, most kids have gotten back what it is that they're going to get back. So let's say you have a little bit of triceps function. Chances are that triceps function, at 9 months, chances are that triceps function will continue to improve. If you have no triceps function by 9 months, chances are it's not coming back, right? I'm not going to be the person who tells a child, no way, never, that's never coming back, but the odds come down, right? And it's all an odds thing. So the odds of successfully getting that triceps to fire when you're doing a nerve transfer are higher at 9 months than they are if you wait for natural recovery. When you get to 12 months, probably the same. When you get to 2 years, probably better, the nerve transfer. 3 years, I don't know, probably, but right, because the chances of nerve recovery spontaneously at 3 years from AFM is really low. What is it with the nerve transfer? We just don't know. We don't have that experience.
We would need biopsies of the muscle to see really, to make that, answer, to give that answer.
Yeah,
I'd like to ask about preserving muscle health, and you were talking about kids having their muscles, not dying as quickly as adults. Are there things like e-stim that families can be doing to help their children retain that muscle health and perhaps make the muscle more likely to be reinnervated?
I don't think so. I mean, I don't know that literature well enough because it's just not something that's been present in my practice for patients with acute nerve injury. I don't know that stimming the muscle when there's no electrical activity getting to it makes a whole lot of sense. If it's stimming something that's coming back and it helps the patient identify, oh, I'm stimming the muscle here, feel that contraction. Oh, and now I've made it. Now I feel what that feels like and I can make that contraction more quickly. Great. But if there's no signal to it, I don't think you're really helping your muscle. I don't know, Dan, what do you think?
So, this is a question that keeps coming up, and not just for AFM, but also for spinal cord injury and a variety of other nerve injuries. There's really no evidence that electrical stimulation does anything to either help nerve recovery or muscle recovery if you're stimulating the muscle, right? There is some evidence that if you stimulate the nerve, that does tend to improve the ability of the nerve to recover if the nerve's already on its way. So the way I think about it, the nerve recovery is like a marathon, right? You have all these people running. Each one of those is an axon. So each one of those is a nerve fiber, right? And nerve stimulation is like the guys who are cheering them on, right? But if you're at the finish line and you're cheering them on, I'm not so sure that they can hear you. That makes sense? Like, it just doesn't make, stimulating the muscle doesn't do anything to nerve recovery. And there's no evidence that it does anything to preserve the muscle. I'm going to be a little controversial and say that there is one thing that has been shown so far in animal studies to preserve muscle, and that's growth hormone.
That's interesting.
That's it, that I'm aware of. That's all that I'm aware of. I don't know about you, Amy. You probably know more than I do.
No, I don't know of anything that preserves the muscle. I mean, there's a lot of, scientific rigor trying to save the muscle and the motor end plates and the little cells that receive the input that keeps the muscle cell alive. And the only way we have, as surgeons and even as surgeon scientists, have figured that out is by getting something to it sooner. Speeding up regeneration, it's really hard to do. There's only one agent that allows for that, and that's tacrolimus, which is a immunosuppressant and has side effects that are associated with that. So we don't tend to use it clinically, although probably could. We've studied electrical stimulation in our lab, and we find that if we use your marathon analogy, it's that, at the start of the marathon, everybody's right there at the starting line and everyone takes off at the same time. That's sort of the analogy of what electrical stimulation is doing. It's causing less staggered regrowth of the motor neuron. And that's exciting because if you have staggered growth, then you don't get all of the people to the finish line at the same time. And if we can get all of them there closer, then more hits the muscle more efficiently. So there's a lot of electrical stimulation that I'm excited about if the connection's intact. Not so much.
But to the nerve. Yeah, right?
Correct.
On the nerve, not the muscle side.
Correct.
I think that's an important distinction.
Yes, thank you.
Well, I love go ahead.
Go ahead. No, go ahead, please.
No, I was about to move on. So if you have something else to say, go for it.
Well, I think that one of the things that we're seeing is this diaphragm pacer. I don't know if Amy, if you're seeing those, but some kids are coming to us.
Yeah, we wanted to hit some nerve decompression questions and then hit some of the diaphragm phrenic stuff.
All right, I'll leave that for later. All right,
okay, great, because we're very interested in that. But so with the 2016 group, we had lots of chatter about the nerve transfers, and we're hearing more and more people talking about nerve decompression now and having questions about nerve decompression. So we have a whole bunch of ones specifically for Dr. Moore. So we'd love if Dr. Moore, if you want to talk about the nerve decompression process. Personally, we're bringing our son to you next month to do this, and he's 3 years out. So we'd love to hear just kind of how nerve decompression works, if you want to go over the basics of that.
Sure. So I did not, it came to me, right? So I didn't go looking for this nerve decompression. And when we do a nerve transfer, you always free up the nerve from the surrounding soft tissue. And that alone may help. So here's my scenario. These patients get this virus that attacks something attacks the spinal cord. That allows for swelling of the spinal cord and those motor neurons and everything distally. We know after a nerve injury, the nerves swell, both proximal and distally to the injury. And so now we have this child who has all these swollen nerves. Again, this is my, theoretically speaking, not scientifically rigorously studied, but here it is. My theory is that now that they're paralyzed and there's not any movement and there's no one really moving these limbs, and so you have a swollen nerve, and a nerve entrapment, meaning a nerve decompression, is just saying that the nerves all through our body are covered by fascia that's fixed. The tunnel is a fixed space, but if you have the nerve itself swell, then the passing of that nerve, it's sort of like taking a 4-lane highway down to 2. And you all know on the traffic can be backed up, right? So the idea is, well, if we free up the soft tissue that's surrounding the nerves and the tunnel all of a sudden is bigger, Then in time, slowly we can get all the traffic and cars to where they need to go. And so my theory is that, that's might have been why I have had these crazy, exciting, and truly unexplainable recoveries, except to say that no, the nerve was compressed. There was this ischemic, conduction block. And I first witnessed it in a 2016 cohort on a young boy who has weaker left leg. And we did an operation on his arm, for a nerve transfer on his arm, but I said, okay, well, he's really tender over his femoral triangle. Let me just free this up and see if we can just, explore and say maybe he'll be a nerve transfer candidate. Well, he wasn't a nerve transfer candidate, but the patient came back and said to me, he's 8 years old, and said, wow, I feel so much better. I wish you would have done the other side. And this is an 8-year-old kid. And that was the first trigger that this is a painful issue. I ask about pain with almost all of the patients. And a decompression is simply freeing their nerve up from the surrounding soft tissue. And now I've had these, miracles a bit where they had no movement, and we free up the nerve, and within 3 to 5 days, against gravity motion has been witnessed. I've seen it. I have videos of it. I've shared them with Dr. Z. I don't have an explanation otherwise except to say that there is soft tissue that gets stuck. It's sticky. It's not really scar tissue. I think it's fibrinous tissue. The nerve's unhealthy. It's swollen and gets stuck. And so that's what I'm doing, and I believe it. I full-heartedly believe it, because I've seen incredible results.
I mean, people are unbelievably excited about this with good reason, because when we're looking at nerve transfers, you're talking about a very long period for the nerve transfer to show any progress. And these nerve decompressions are a much shorter window to actually see things happening. So it's something that's very exciting for families. So you were talking about the pain. Are there other indicators that a nerve is compressed and that a decompression might help restore movement?
Here it goes. So on two of the children, they had EMGs not done by my facility, one being done by my facility, which showed motor unit potentials. So there was an EMG, they stick the needle in the muscle and then they record, and they ask the patient to move the muscle if they're old enough to participate, and this child was. And there were activation of the units of the muscle. And so I was like, well, that's interesting, but he's got no motion. And so in my head, I was thinking like, oh, well, this may be a very exciting, intraoperative experience. And then we get in there, we release the nerve. You have to release the nerve to get to the nerve. It's just what happens. There's no testing the nerve before you get in. But then stimulating the nerve intraoperatively, I knew that, or I just really felt it, is like, well, this kid's going to be able to move his leg. And so there was no way to really predict except, okay, well, I had an EMG that showed that the muscle has something to it, and then a physical exam that showed tenderness over the site of entrapments, which we know those entrapments exist for things other than AFM. And so why wouldn't it also be applicable? Dan, I want to hear what you think, because you're seeing a lot of the same patients and you're probably thinking I'm a little bit crazy. I am. I'll take it.
I think you being crazy is the question here. No.
That's a confirmation. Okay, perfect. Now what do you think about my theory?
Well, I think that there is some basic science to support this decompression concept. I think that if you, as you said, the nerves do swell, and I think we have to go back to the causation of this anterior horn cell problem and the initial insult from the virus to the body, right? If you look at the animal models of acute flaccid myelitis, and particularly enterovirus infection, the primary insult may be and replicating at the muscle, particularly for some reason shoulder girdle muscles. And then it can cause extensive damage to the muscle there, and then crosses the neuromuscular junction into the axons or into the actual nerve fiber. and then travel the spine. And that's why it's specific and spotty in that it's almost like a sniper taking out very specific muscles. And one muscle may be affected and next muscle may not be affected at all. And so I think that if you consider that and you think that there is damage to the nerve all up and down the nerve, right? And then whatever fibers happen to be surviving are surviving in an environment where there's a lot of swelling and a lot of damage, and there's a lot of active physiologic processes that are trying to get rid of all these injured nerves and also to repair injured nerves. That is all causing swelling. And I have seen some patients, and I would say it's not common, but I have seen patients whose nerves just looked, they just didn't look right. I don't know how else to say it. They're not normal looking nerves. The majority of kids that we've taken care of have normal looking nerves. They look healthy. They don't look entrapped. They don't look swollen. They look fine. But there's a certain subset of patients where those nerves just don't look good. Now, I don't know what to do with that per se. And I think that the question for us is, when do we do, because I think what you said is really important. It's very exciting to parents to do less and get more, right?
Yes, obviously,
but
yes.
But the reality is that I think this decompression concept does not apply to the majority of patients. And it's not something that I think you could tell preoperatively, other than patient maybe has some tenderness at a point where nerves tend to get compressed, right? Because you can't decompress the nerve along its entire length. You would effectively kill the nerve, and it's not practical. That's a big dissection. But you can find sort of spots where the nerve is spot welded, and you can maybe free up those particular spots, and they may be tender there, right? But I think still you have to go in with the mind that I am going to do something to this nerve, and maybe it's release. If you have no transfer options, then the answer is maybe I'll do a release, because what do I have to lose, right? But if you do have a nerve transfer option, again, I think it's an odds game. Your odds of getting function back from a nerve transfer, I think, are better than a nerve release, except in cases where you stimulate the nerve intraoperatively and you get function distally, and then you get no function distally, and then you release the nerve, and then you stimulate again, and you start getting function. And that I have seen. So in those
that's
cases,
when we're all like
you leave it alone.
Yes.
That's when you high five each other. Exactly. And also I would say it helps to see that the nerve was compressed. So I think this is one of those things that like parents ask me about all the time, and they're super excited, and they've heard all about this, and are you going to do a decompression? Are you going to do a compression? And as Dr. Moore said, you do a decompression as part of your nerve transfer anyways, right? It's the first step. And so then you're stimulating and seeing whether your decompression did anything. If it doesn't do anything and you don't see any evidence of compression, then I think you move on to the next step. Is that fair, Amy?
Yeah, totally. And so I don't think it replaces the nerve transfer. I think that it is an option for maybe those who have function, but it's not full range of motion. So, for example, you have deltoid motion, but you don't have greater than 90 degrees abduction, meaning the shoulder doesn't come halfway up. And then you push on the quadrangular space, or this little spot in the back of the shoulder, and the patient, these are little kids, like they don't do it. You push on, they go, ow, and I'm like, oh, isn't that interesting? You go to the other side, they don't say that. You go back to it, you distract them, whatever, you push on it, and they go, ow. And then you're like, okay, well, I think I can release that and it will help.
Okay. Well, can I ask we want to make sure we get through, we have a lot of questions. So let me ask you some quickly so we can make sure we have time to talk about Phrenic stuff as well. So do we have a timeline for nerve decompressions? We're talking about 9 to 12 months for nerve transfers. What about nerve decompressions?
None. I don't think it matters. I think that if muscle's dying and those, we're down, the compression has put us at only 1 lane versus 4, then maybe there is a time window. I think that if we're doing it for discomfort, to free the nerve up as these children are growing rapidly and the nerves are tethered, then I think that there's really not a timeline.
Okay, that's great news. Nerve decompression is something that you think may help when a nerve transfer is not possible. So the question is, if nerve transfer isn't an option, could a nerve decompression still help? Which I think you've addressed some.
Yeah, I'm afraid of offering false hope, and
Okay.
I'm afraid of being out there on a limb. And you know, when I entered into this patient population, my communication with the families was the most important part. I was willing to try a new procedure and put their child under the risk of anesthesia because the risk of what I was doing was going to be very little, and the potential benefit was high. And so as long as that parent is fully aware and we have that discussion and they understand that this may do nothing, well, then I think it's reasonable for me to do it. But it's really one of those, it's, you know, if I decompress and maybe they hurt a little less and maybe they get something, I don't have enough information to say it's going to restore them. And it's certainly not in my mind thinking it's going to make them normal.
Right. And you answered this a little bit as well. We hear nerve decompressions being talked about mainly for legs, but it sounds like it can be done for upper extremities as well.
Oh yes, I mean I've done many to try to get better motion at the shoulder.
Okay, next question. Is nerve decompression an option for someone who has both white and gray matter damage? For instance, if a patient has flaccid paralysis on his upper extremities, but spastic paralysis on his lower extremities, could it still be beneficial?
I don't know. I haven't seen that. Sorry, I haven't seen that in my exams. It would have to come to an inpatient visit where I can actually examine to know.
Okay, well, I think this person is headed to you.
I don't know if that would. Yeah, I don't know if that would make any difference.
Okay.
Whether they have. So what you're getting into is one of our beefs with the CDC is that the CDC really defines AFM by radiographic and so it's sort of imaging criteria, age criteria, but there's no real diagnostic criteria in the sense that the way we define AFM as clinicians is not what you're describing. What you're describing in our minds is transverse myelitis. So, and that's a generally an entirely different presentation, right? But there's no reason why a nerve that is recovering could not be helped necessarily by decompression as long as the same criteria apply, right, Amy?
Agreed, completely agree.
Great, thank you so much. So kind of moving on to Dr. Z.
So the question is, what can be helped when the phrenic nerve is damaged? What can be done to help respiratory function? So decompressing the phrenic nerve or a diaphragmatic pacer. If you want to go over what you guys are doing, that would be great.
Yeah, I'm not really sure you can decompress the phrenic nerve. The phrenic nerve is, I don't think it has any discrete areas of compression. Amy, do you know of any discrete phrenic nerve compression sites?
No, I don't know that enough. I'll defer to you.
Yeah, I mean, the phrenic nerve travels along the anterior scalene muscle. There's really nothing in front of it. It sits in a fairly protected, you can imagine it is a very vital nerve, and therefore it is not one of those nerves that's subject to compression points or areas where it can be injured easily. It's not that kind of a nerve. And it travels on top of the heart, actually, and down into the diaphragm. Now, I think that just to give you a little bit of primer on anterior horn cells versus other nerve disorders, right? And we've sort of, the whole picture has been muddied by transverse myelitis, which is a very different disease process. So there are two basic ways to get the diaphragm to contract when the phrenic nerve is not working, right? When the diaphragm is not working, right? One is to put a stimulator directly into the muscle, and we've alluded to that with this stimulation of muscle problem, right? So you can put a stimulator on the muscle itself, and that's the diaphragmatic stimulator, which is put in from underneath, from the belly onto the diaphragm. And those are basically little electrodes that go into the muscle, and you can pace those, right? And so the diaphragm will fire if you stimulate the muscle, right? As you can stimulate any muscle that's alive and healthy, will move when you stimulate it. That technology comes from the spinal cord injury patients. Now, spinal cord injury patients who require their diaphragm to move typically have a high cervical spine injury, which means that their anterior horn cell to the phrenic nerve is actually fine because the injury is above that. Their brain doesn't get the signal to the anterior horn cell to tell that anterior horn cell to make the diaphragm move. But there's nothing wrong with the anterior horn cell and diaphragm connection, meaning there's nothing wrong with the nerve. And in those patients, a diaphragmatic pacer actually works very well because the nerve, again, you need that nerve to maintain the muscle. Without that nerve muscle combination, the muscle goes away and dies, right? So I think these people who are putting in diaphragmatic pacers into patients with acute flaccid myelitis do not understand the basic physiology of the disease. Because, again, when you have acute flaccid myelitis and loss of the anterior horn cell, which is what we know is the disease process, that entire phrenic nerve is going to die, and therefore the muscle itself is going to die unless you bring new nerve into the diaphragm. So you can put these stimulators into the diaphragm, and they will work for a year, maybe a year and a half, and then after that, they'll disappear because the muscle will disappear. But what we're trying to do, and I think that this also comes from the spinal cord injury world, is the phrenic nerve pacer. Now, if you have again, high level spinal cord injury and the anterior horn cell is doing fine, you can put a stimulator around the phrenic nerve itself and fire the diaphragm using just that phrenic nerve stimulator. That's a nerve stimulator instead of a muscle stimulator. And it will fire the muscle in the normal way, carrying the signal down the nerve, which is alive, into the diaphragm. If that anterior horn cell is dead, as in the case of some patients with spinal cord injury, whether you use a phrenic nerve pacer or a diaphragmatic pacer, it's not going to work because that nerve is not going to work. And so in those patients, in spinal cord injury and in acute flaccid myelitis, you can transfer a working nerve from somewhere else into the phrenic nerve to reconstitute that nerve supply to the diaphragm. And then it doesn't really matter what you use. You can use a diaphragmatic pacer or a phrenic pacer. It's irrelevant because now you've reconstituted the nerve supply to the muscle, right? The other option that's unique to AFM patients is the most likely thing to transfer is the intercostal nerve. Now, the intercostal nerve is a fantastic nerve to transfer, A, because it's locally right there and it's an easy reach, and B, it's a muscle that you're using for breathing anyway. And so the benefit of an intercostal to phrenic nerve transfer is that you don't even need to pace it because your brain will automatically fire your intercostals when you want to take a breath. And so it's actually a much more elegant solution than in any other patient population. So, all right, you can ask me questions on that. There's a lot to digest.
Yes, yeah, that is a lot. So yeah, there's a lot more nuance to the different scenarios than I realized. So how would someone know which kind of case they are? It sounds like there were maybe 3 different options if I was tracking correctly.
So if you have acute flaccid myelitis, meaning you have an anterior horn cell disease, then you need a nerve transfer, period.
Okay. So, because we've had some kids who've gotten the diaphragmatic pacer, but because AFM kids have sensation intact, it's been uncomfortable for them. So that's
Yes,
kind of a separate issue, I guess.
that is yes, that is true, and you will
Okay.
feel that and it'll be very uncomfortable. But
Okay.
part of the reason why they're uncomfortable with it is because when you put a diaphragmatic pacer in, you need to up the juice so high because that muscle is dying, because there is
Okay.
no nerve that's maintaining the muscle. And so under normal physiologic conditions, with an innervated, meaning a muscle that has a nerve, you don't need that much electricity to make it fire. But if you're going to put a diaphragmatic pacer, which in the long term will fail, then you have to keep chasing after and putting more and more electricity into the muscle as the muscle is withering away in order to get it to fire. And that's an uncomfortable voltage to put across anybody. So that's why it hurts.
Okay. So your recommendation, if someone is using a vent full time, is the best like diagnostic to see if they're a candidate coming in and getting an EMG, or what is the diagnostic for phrenic nerve transfer?
So the best nerve is going to be an intercostal nerve. In order to test whether the intercostal nerve is working, you really need to do it under general anesthesia because it's too dangerous to do it. You have to put a needle right next to the lung, and that's not something that you want to do with a jumpy child, right? So it does require anesthesia, but that's really the only way. And I can tell you that we've had EMG verified usable nerves that were not usable, and we've had EMG non-usable nerves that were usable. So I don't think it's actually a fully correlated test. Does that make sense? I'm not
Yes.
sure that it's reliable.
Okay. Yeah, that the phrenic nerve and all the breathing things is a little bit scary to try to iron out, but it's so critical for quality of life.
Yeah. Amy, could I ask Amy a question?
Yes. Please. Sure.
So does stimulating the diaphragm with a diaphragmatic stimulator in the case of no phrenic nerve function make sense to you?
No, it doesn't. I think your explanation was very, it was very good. It doesn't make sense to me from a physiological standpoint, because it's the same thing about e-stimming a muscle that has no proximal control, and it's just going to burn out all of the the neurotrophic factors and all of the things that allow muscle to contract. And I just think of the diaphragm as another big muscle that's just, seriously more important.
Yeah,
I don't know.
I just don't see any role for placing a diaphragmatic pacer in anyone who has acute flaccid myelitis. That doesn't make any sense to me. So okay. I would say if there's somebody in the audience who's about to have one and really has acute flaccid myelitis, not transverse myelitis, but acute flaccid myelitis, I would say there's no role for that except for this. If you have some phrenic nerve function early on, right, and you want to be weaned off of it in the first 6 months or a year, and knowing that that's all you're buying yourself maybe 6 months or a year of less reliance on ventilator, and you're willing to go through that operation knowing that it's a temporary support measure to try to minimize your dependence on a vent, I think that's a reasonable thing, but you have to know that's what you're getting into. Does that make sense, Amy?
Yeah, no, I think that's great. Like if you're doing it to help transition, I think that makes sense to me. I think it's really hard. It's really hard.
Yeah, I think
it is not a long-term solution. Yeah.
I had one more question kind of related to the phrenic nerve stuff, because most of the nerve transfers are, arms and legs. And there's a segment of the kids with neck weakness and swallowing issues, my son being one of them. Is there anything that is being done anywhere that you know of that helps with neck or swallowing?
So it's interesting. I was talking to one of my partners, Allison Snyder-Warwick, who does facial nerve reanimation, and not for AFM, but the idea of what could we be doing for these children with the neck? And it's very profound, right? And so she was asking me, well, do they have normal tongue function? And I said, well, I don't know. I've never asked them to stick their tongues out. But there are two good nerves that move the tongue, which are right in the same area of what controls the muscles to the neck. And she says, well, why couldn't you just transfer that hypoglossal nerve, which is the nerve to the tongue, and transfer it to one of the neck muscles? Again, never done it. Thought it was genius thinking about it, as we've used that nerve to power, different muscles after brachial plexus injury, although not commonly used. That was sort of the best opportunity I saw, but haven't done it, of course.
That's very interesting.
Yeah,
Well, go ahead.
Yeah, I was gonna say that I think part of the difficulty is that the reason really these nerve transfers are catching on is just an accident of fate, that people sort of wandered into the right clinic, right, of somebody who does nerve transfers,
right,
in the upper extremities. And then they wandered into Amy's clinic, and she was doing lower extremity transfers. And I think it's just a question of somebody wandering into the right clinic of somebody who does nerve transfers around the neck. That I don't know the anatomy there. Amy knows more about it than I do, but I think that there's somebody there who's doing facial reanimation, that if your child has an issue up in that level, then it probably is worth finding one of these, for Amy and I maybe, to do a little diligence and find somebody who's willing to do it, and connect this group with that person.
Yeah. I mean, my partner is willing to do it. I mean, we also have a lot of redundancy of the facial nerve. It's just we just haven't done it. I mean, we need to go to the cadaver lab, which we have access to after we identify the right patient, and then see if it's feasible. It's exciting. It's another avenue of, of creativity and innovation to help a patient in need. I didn't know any of these nerve transfers I did before I had a patient who needed it. So to be determined, I guess.
Yeah, I mean, we're discovering nerve transfers. Necessity is the mother of invention, right? I mean, we're doing nerve transfers now that have never been described. I mean, we do it on a fairly routine basis, where we say, hey, this nerve is working, and it's right next to where the nerve isn't working, and let's try it. And that's on the level where we are. And so I think that as long as we feel we're not going to cause any harm, and we think there's a chance, and we don't have any other options, which is sort of where this is taking us, is taking away a lot of our options. And so we're being forced to be really creative. And in the face, the same thing. I mean, we've seen plenty of kids with facial droops and facial nerve paralysis, etc.
Right. So exciting. It's so exciting. So I know we're almost done, but I really want to leave the families with, a sense of hope, in the sense of, if there's more questions that we can answer, I'm happy to take them on. I think that we are learning more and more with every patient that we treat. I have some exciting, exciting information from the lab that's going to, I hope, figure out so that the 2020 cohort, has an even better chance. I applaud the families for getting more information. Rachel, I totally am excited about what you're doing with, this association, and I really am grateful to be part of it.
Well, just on behalf of the parents, we are so grateful for both of you and all the surgeons doing transfers. And I mean, you're very beloved by our community and really have brought a lot of hope to these families and have just changed the lives of these kids. And everyone is very grateful for your time today and all the time you put into this work.
Yeah, you're welcome.
Thank you. It's very kind.
Well, thank you both for joining us. We're so thankful for your time. I am sure this podcast will provide a lot of information for parents who crave, more knowledge about their kids and the future. So that is the end of our hour. We will be hosting another podcast on nerve transfers in AFM on Monday, August 12th at 4 p.m. And this podcast was recorded, and that one will be as well. So if you submitted a question that we didn't get to, we will try our best to address as many as we can on Monday. So on behalf of the TMA, thank you all for joining us.
Great, thank you.